Okay, so welcome to the CPD meeting. We've got Dr. Tom Boyles doing a talk for us on clinical management of suspected or confirmed COVID-19 disease today. He's an infectious disease specialist working at Helen Joseph Hospital and has also been helping us with the COVID response in Joburg Metro District. So welcome, everyone. I think if you have any questions and answers, just put them in the write them into the question and answer section and not the chat group, because I won't watch that one. And then I think, Tom, questions and answers at the end, hey?
Yes, I mean, I was like to keep, if people want to ask a question in the middle, I think that would be fine. If I was doing this live, then I'd be very happy for people to put their hands up in the middle. So why don't we try and do it as if it was live? See what happens.
So if you can put your hand up, I hope someone will notice.
Yeah, that's the thing. If they don't, then we'll have to do it at the end. I apologize, but yeah.
Okay, so thanks. I think just go ahead.
Okay, great. So thanks very much. So this first slide is the first page of this document, Clinical Management of Suspected or Confirmed COVID-19 Disease. You see it's version 4 and it's dated the 5th of May. And it's endorsed by the NICD and the Department of Health. It isn't actually endorsed by them yet because it's awaiting a signature. So this is not publicly available. And so I think it will receive a signature and hopefully it will be out soon. So just so that you know that I'm sharing it with you, I was one of the authors on it and I'm very happy to talk you through it, even though it's not technically publicly available just yet. You may, I'm trying to go to the next, how do I go to the next? Sorry, excuse me. Okay, sorry, it's just a bit slow coming through. So I'm going to show you the first thing, which is what's new, mainly because of the things that were taken out of this section, because you wouldn't otherwise know that. I'm not going to talk through the things that are new. I'm going to talk through them as they come in, but things that have been taken out, I'm going to talk you through. So recommendation against the use of rapid antibody testing. So essentially rapid antibody tests are, well, there was a report today suggesting that there's one that might be reasonably okay in the UK, but in general, they've performed really badly. And they certainly have no value in the acute diagnosis of acute disease. The removal of the requirement that mild disease in high-risk individuals requires hospitalization. So that was a previous recommendation, and we no longer think that that's true. If people have mild disease, then they should be managed either at home or in an isolation facility, but not in a hospital bed. And the other things are all additions that we'll come to. So let's move on to what is actually in the guideline. So the first thing you need to do, of course, is to suspect that somebody has COVID. And I'm going to show you a little bit of data on this because I think it's quite interesting. The question is, what symptoms predict somebody having COVID and how should we use symptoms to decide who to test, essentially? So there's lots of literature out there right from the very beginning of COVID about what the symptoms are. And they're always presented in lists like this. So common, less common. So common, obviously, fever, dry cough, and tiredness. Less common, but they're aches and pains, sore throat, diarrhea, conjunctivitis, headache, loss of sense of taste and smell, and skin rashes. And then serious symptoms, shortness of breath, chest pain, and stroke. The problem is that what they don't tell you is, so it's fine to say, well, someone's got a fever and a dry cough, fine, so they're in. But if in the people who don't have, did the people with fever and dry cough also have the sore throat, the diarrhea, and the conjunctivitis, in which case those three symptoms are not much value? Or did people with sore throat, diarrhea, and conjunctivitis actually not have fever, cough, and tiredness, and therefore that's helpful? And those are very rarely presented. So it's very difficult to say in someone who doesn't have, let's say, the first three symptoms, whether you should be considering them a case or not. For example, if someone has a young stroke, if a 35-year-old comes in with a stroke, should you consider that person a suspect for COVID or shouldn't you? I don't have an exact answer for that. I think if they have a fever, then clearly you should. If they don't have a fever, you probably shouldn't, but it's difficult to be absolutely accurate on that. So this is not technically in the guideline, but it should be. because we need a way of screening patients when they arrive at our facilities, primary, secondary, tertiary. We need a way, we need a highly sensitive screen so that we can, and it has to be rapid, it has to be simple so it can be performed by community health workers and the like, that we can divide people into high risk and low risk people. And so this is what we've been using, and it really, you hear a lot about screening in the press, but you don't actually hear somebody giving you a screening definition, which is a bit disappointing. But the screening definition we're using is any one of cough, fever, that's a subjective fever, shortness of breath, or sore throat, or the number 3 there, which could be under number 1, a very obvious loss of sense of smell or taste. So any one of those 5 screens you positive, plus a worsening of a chronic cough. So we don't want to miss somebody who's been coughing for a year because they are a smoker, and then in the last 7 days they've got much worse because they've got COVID. We don't want to miss that. Sorry, I didn't say explicitly the top line. These have to have started in the last 2 weeks. So generally somebody with 4 weeks of cough would screen negative, because COVID does not present after 4 weeks of cough. It presents within the first 2 weeks of cough. But we don't want to miss people with chronic coughs who have recently deteriorated. Okay, I hope that's clear. I'm just seeing if anyone's got their hand up. If that would show up on my screen, I don't know. Okay, so I just want to show you, I'm not mostly going to show you evidence, but I just wanted to show you a couple of things because I thought they were interesting. This is a paper published a couple of days ago in Nature Medicine, so a high-level paper by a group working mostly in the UK who used symptom tracking using a smartphone app. So this is really people, so essentially they wrote this app and they put it out on all sorts of media, and within 3 days, 2.5 million British people had signed up. And there was a similar, something similar happened in the United States. And essentially they asked people in the community to just of their free will to log all their symptoms. So if they woke up in the morning and they had a symptom like a sore throat, they logged it into the app, and they did that every day. And then some of them went for tests and some of them didn't. But the ones who went for tests, they got the result, and then they looked at what the difference was between the positives and the negatives amongst those people who went for a test. So you can see there are some limitations to this. Not everybody went for a test. Some people with symptoms didn't go for a test. So it's not a perfect set, but I think it's quite interesting. This is what they found. You see United Kingdom, United States, so they found similar things, but these are the odds ratio of one of these symptoms predicting that you actually had COVID. And you can see that loss of sense of smell is a standout performer. So it's hugely predictive. And this has been found in other studies. Basically, if you've lost sense of smell, you're 10 times more likely to have COVID than any other symptom, or than somebody who hasn't lost their sense of smell. So I think it's very justified, despite the limitations on this data, to include a loss of sense of smell. Interestingly, there are things that we don't ask, like skipped meals. The next most predictive factor in both countries is, have you skipped a meal? Which we don't think about, we don't ask, but that's interesting. And other things like chest pain, actually, people with chest pain right at the bottom, were neither here nor there. Abdominal pain, neither here nor there. Shortness of breath is hardly a predictor. Again, these are relatively well people out in the community, but I just thought that was quite interesting. They came up with a prediction model. And so you can see that in their prediction model at the top there, older age, that's older age, male sex, loss of sense of smell, severe or significant persistent cough, severe fatigue, and skipped meals were all independent predictors. And the model as a whole is not fantastic. That curve there is 0.76, and whereas 1 would be a perfect and 0.5 would be terrible. It's about in between, but just gives you some idea. And if you're interested, I'm working with these people trying to get this app rolled out in South Africa. I think it would be quite interesting despite the limitations. So any questions on how you're going to suspect, I don't know if the hand up thing comes, but on this is, how you would suspect somebody of having COVID. Don't see any hands. Okay. So the next thing you really want to do when somebody has been, so we've screened them, very unlikely to have COVID or may have COVID. So you then are going to see that person. They were screened by a community health worker. They're then going to come to the clinician, which is you. And the first thing you should do, I think, is determine the severity of their illness. We don't know what illness they've got at this point. It could be anything. It's likely to be a respiratory illness, but it could be pneumonia, could be TB, could be PCP, could be COVID. First thing to do is determine severity. And this is pretty standard way of determining severity. And it gives you an idea of who's going to need to proceed to a hospital or a casualty and who you should be able to deal with and send home. And that's quite important because you don't want people with COVID coming into the hospital. You're right into the hospital if it's unnecessary. So this is in the guideline. And this is something we can measure using a SATS machine, a watch for respiratory rate, and temperature, and you can talk to the person. So you don't actually have to touch the patient. If you've got an infrared thermometer, you can get all 5 of these readings and determine severity. And if they're mild, then you should be able to deal with them without them going much further. If they're not mild, then they probably need to go inside, either depending where you are, either in an ambulance to an emergency department or into your emergency department. So that's severity scoring. Sorry, I'm just struggling with my computer. It isn't listening. Okay, now it's listening. Okay, so who are you going to test? So now they've had their screen. We know it's very sensitive and not very specific, so you've got a few extra people. So this is actually from the guideline, and this is almost the same as the screening criteria. And it's not the same as the PUI definition. So this is where life gets confusing, because the PUI definition, the person under investigation definition published by the NICD, is very old now in the COVID terms. It's well over a month, probably 6 weeks old. And in COVID terms, that's out of date, but it has not been updated. Apparently, the people who do these things have been arguing about it, and it's therefore stuck. And so we don't actually have an up-to-date PUI definition. So in the absence of that, the people writing this guideline had to come up with people we think should be tested. It's not ideal because you really want it to be the same as the PUI definition, but that's the way it is. And so we came up with this, which is almost the same as screening. It just doesn't include fever. So someone who has just a subjective fever, i.e. feels a bit feverish, but doesn't have any symptom, according to this, wouldn't get a test. But it's cough, sore throat, shortness of breath, new loss of sense of smell, or altered sense of taste, and they usually go together, or an acute exacerbation of a chronic condition. So it's basically the same. Things are going to change. Obviously, a PUI definition will come out, and we hope it'll be the same as this, but we can't guarantee it, and it's unfortunately just going to cause confusion, which I'm unable to rectify. So you decided who to test. The other people who you don't test, you're going to have to, they've got an alternative diagnosis that you need to think about. The ones who do decide to test also may have an alternative diagnosis. So you haven't made the diagnosis of COVID yet. You've just decided who requires a test. And then what are you going to send? Well, there are upper respiratory tract samples and lower respiratory tract samples. Generally, we're sending, so the guideline says a single site is enough from the upper respiratory tract. Nasopharyngeal is preferred over oropharyngeal. Saliva is emerging as an alternative, but at the point that this guideline was sent, we did not have updated guidance on using saliva. So again, this could change very quickly. This is in the mix. FDA has approved saliva testing. It probably works. We're just waiting on the lab people at NICD to do all their validations before we can probably switch from swabs to saliva. But I can't say that definitively at this very moment. Lower respiratory tract samples are excellent, probably the best samples, better than an upper respiratory tract one. You must not induce sputum, it's too dangerous. But if someone is producing sputum, or in sick people, they've got an intubator, they're intubated, But if somebody is able to produce sputum spontaneously, that's an ideal sample. If you can send both, but sputum probably is the best sample if the person's producing. Okay, so you've now tested your patient. You screened them, you've tested them, but you still don't know if they've got COVID. And so you're going to have two kinds of patients we're going to talk about. The one with mild disease, who's we're going to try and send home quickly. That's at the bottom, and I'm going to come on to another slide on that. But you're going to have the sicker patient with severe disease, and they're going to require admission to hospital. They're going to get a test. Unfortunately, the tests are taking multiple days to come back. So you're not going to have a COVID result immediately. And so you need to think about other possibilities. This is what we're suggesting as a range of tests. You need to know the HIV status. That determines a differential diagnosis in terms of things like PCP and also TB to some extent. A full blood count, a blood culture, a nasopharyngeal, oropharyngeal swabs for viral and atypical pathogens that may be available or it may not. A chest X-ray, chest radiograph, sputum MCNS is probably the least important, but it's on the list. A test for almost all these people will require a test for TB. They've got, by definition, a severe respiratory condition, so they should have a TB test with sputum and urine LAM if HIV positive, regardless of CD4 count. I'll come on to something a little bit later about PCP and beta-D-glucan, but we'll cover it in a bit more detail. But in this instance, we're suggesting beta-D-glucan and sputum for PCR for PJP. So that's just that's basic set of investigations, and then based on all those results, then you need to make a decision about empiric therapies, which we'll just come on to later. Yeah, later. I just want to go through an algorithm for outpatients, so non-severe people. This is the kind of algorithm. This has been thankfully incorporated into this guideline, but it's essentially the algorithm that we wrote for City of Johannesburg. So you've essentially got a patient with a less than 14 days of respiratory illness. Essentially, that's largely what these people will have by definition. If it's more than 14 days, they shouldn't be there. So it should be less than 14 days. It's a respiratory illness. It'll probably include a cough. So what do we need to do? We need to know their HIV status, because that determines whether or not they are a PUI for TB, essentially a TB suspect. I think that phraseology is out of favor. So we need to do a rapid HIV test. If they're positive, we need to send a CD4 count and a reflex CRAG. And if they're HIV positive, or if they're a close contact of someone with TB, then they should have a sputum gene expert sent. Treatment, they need treatment according to EDL guidelines. So in general, someone who's HIV positive, I would generally give them antibiotics. There's debate about that, but I think it's sensible to give amoxicillin or similar to an HIV positive patient who suspected of having TB. There is some evidence that it's useful. Generally, in a patient who's HIV negative with a short duration of cough that's non-severe, they probably don't have pneumonia and they probably don't need antibiotics. So that's one of the reasons that the HIV test is helpful. And then the patient's going to go home with whatever antibiotics or not, paracetamol, whatever. If their gene expert's positive or their reflex CRAG is positive, then they need to be called back. And we don't have time to wait. We need to get them on TB treatment or fluconazole and ARVs if they're CRAG positive. On the right-hand side, if their symptoms resolve and those tests are all negative, then they should come back in 2 weeks' time for ARVs. We're not in favor of starting ARVs in patients with COVID symptoms, but by definition, in 2 weeks' time, they will no longer be a COVID PUI because either symptoms will have gone away or they'll have had symptoms for more than 2 weeks. So we don't think waiting 2 weeks is really dramatic in someone who's both CRAG negative and gene expert negative. In the middle there is when to come back, and suggesting that if people are not better after 5 days or they're deteriorating, then they need to come back for a review. And that would be true for any patient who you sent home. It's a very interesting question about how do you monitor somebody who's at home who may have COVID. And this is a question which a lot of people around the world are asking. So we want to send these people home because they're non-severe, but we also want to get them back into hospital if they deteriorate. And the question is, how do you determine that they deteriorated? It might sound easy, but actually nobody's been able to do that in a reliable and valid way. Probably the symptom you're really looking for is shortness of breath. If you had lots of resources, you could give everybody a SATS monitor, but unfortunately we don't have that. So probably the best thing is to tell them that if they are less able to perform activities of daily living due to shortness of breath, and that's probably a sign they should come in. This is ripe for research. If anyone would like to do some rapid research that would be extremely helpful in COVID response, it would be to determine what's the best questions to ask people on the phone, or questions for people to, or information for people to take away with them, so that we will reliably know who is deteriorated and who needs to come back to hospital. This is in the guidelines, not as an appendix, empiric therapy for other pathogens. So this is as we said, we're going to wait maybe multiple days for the COVID result. And if people fit the criteria for any of the above and any of the below, then they should be treated. So they may fit the criteria for community-acquired pneumonia, depending on their chest X-ray, and should be treated according to guidelines. Seasonally, they may have influenza, so it's worth keeping an eye on the NICD surveillance of influenza. I looked at it last week, and there was 0 influenza in the country right now. Interestingly, there was a sort of mini outbreak in the Western Cape in January, which is unusual to do with travelers. But currently, there's 0 influenza in the country, essentially, because there's nobody traveling in. So it'll actually be interesting to see what happens this year with influenza, because there aren't people traveling in, bringing it with them. Maybe it'll be late, maybe it'll be lower, who knows? But we can usually the influenza season starts in the last week of May, more or less. So we should start to see it picking up if it's coming. So keep an eye on that. And patients with who potentially have influenza and it's severe can have oseltamivir. And then we'll talk a bit more about PJP later on. Symptomatic treatment, this is, the numbers don't quite add up, but this is symptomatic treatment of patients. This is home or hospital. This is straight from the guidelines. So we prefer paracetamol to NSAIDs because there's a minor suggestion that NSAIDs might be harmful in COVID. But people who are on regular NSAIDs for their rheumatoid arthritis or any other reason should not stop them. They should carry on, because it's really just a small signal. But if you're given the choice of paracetamol or NSAIDs for symptom relief, then use paracetamol. There's new guidelines about spaces and nebulizers. So nebulizing somebody who with COVID, as you can imagine, is a hugely risky procedure in terms of infection control. So if at all possible, then spaces should be used rather than nebulizers. And that's in hospital and at home. If that's not possible, then and nebulizers have to be used, then you really need to try and find a separate well-ventilated room. In one of the hospitals I was at, Lenasia South, I think they actually had an outdoor space that, and it's not going to be rain right now. They use an outdoor space for nebulizing people, and I think that's absolutely appropriate right now. Whether the person, in reality, whether the person's fits the definition of COVID or not, it would be good to nebulize them in as well-ventilated area as possible. And if you're using spaces, then clearly they have to be disinfected between patients. If one person uses their own spacer, that's different. Inhaled corticosteroids for asthma COPD or topical nasal corticosteroids should continue. There's no reason to stop them. Similarly, short courses of oral steroids for asthma COPD should continue to give. There's no role for cough suppressants such as codeine. Morphine should only be used for other indications. And there's no indication for discontinuing ACE inhibitors or ARBs. A lot of excitement at the beginning about observational data about whether these drugs might be harmful or not. Essentially, there's no good evidence either way, so you definitely should not discontinue somebody and put them at risk just because they might have COVID. Okay, so what about therapy? So now you've got your patient and they've got the positive COVID test. What are the treatments? And I've summarized what's in the guideline. Early supportive therapy for hospitalized patients. Clearly, patients at home, there's really no therapy you can give. But in hospital, they need to have supplemental oxygen if they've got low oxygen saturations, and probably aiming for a saturation of 95 or above is probably appropriate for most people. Judicious fluid management is required. Fluid management is an interesting one. So what you see, or when you talk to people from overseas who've dealt with lots and lots of these patients, what you often find is patients sitting in a hospital bed, not on ICU, for a few days with a high fever and with huge insensible losses. And then they get moved to ICU, and by the time they get to ICU, they're actually really dehydrated. The reason that's kind of interesting is that ICU people tend to not want to give too many fluids. There's good evidence that you should not use liberal amounts of fluids as a lung protective strategy in ICU. So generally they don't want to give many fluids, but clearly you also don't want someone to be dehydrated. So you need to be very judicious with fluid management. So essentially somebody who's on a ward who's got a very high fever, if they're not drinking, then you're going to have to replace that fluid. Probably 2 liters a day. If they are drinking, then you need to make sure they've got access to fluid, because you want people to be neither overhydrated, which is bad for the lungs, or dehydrated, which is bad for the kidneys. If evidence of co-infection exists, then you need antimicrobials. We've discussed that. That's going to be a difficult one to decide which patient requires antimicrobials. There are a few things that might help you. Fever's not going to help you very much. The X-ray is not going to help you very much. The white count is usually low in COVID, so a raising white count might be an indication. Procalcitonin, which we don't usually recommend, is usually low in COVID, so that could be a marker, although it's not great. CRP is usually middle of the road or sort of low end in COVID, sort of 40 to 50 as a median, so a very high CRP might guide you, but that's going to be a difficult one. And then closely monitoring patients for signs of deterioration. That's fairly obvious that patients may need to be rapidly escalated to higher levels of care or need rapid initiation of other therapies such as antibiotics. So specific therapies, this is what everyone likes to get excited about. I've seen some protocols from various ICUs around the world, including Johannesburg, suggesting all sorts of drugs as specific therapy for COVID. And the answer today, on the 14th of May, whatever it is that there is essentially no evidence for any specific therapy, and we should not be giving any specific therapy. Certainly routine use of corticosteroids for COVID is not indicated. And there's lots of sensible people saying that if you need steroids for another reason, then that's slightly different. There's insufficient evidence currently to recommend any specific therapy. And there is insufficient evidence for any drug or vaccine to prevent COVID. So that's treatment and prevention. There are a couple of caveats to that, which are that the world is, as I said, a month is a long time in COVID, and there has been some weak evidence that a drug called remdesivir may have a small effect. We don't have remdesivir here, so it's kind of irrelevant. We're waiting for more data, but so that's a possible. And there was a study showing things like interferon, that a cocktail including interferon may be useful, but nothing that we have access to that the evidence is strong enough to suggest. What we should be doing is, if we can, is enrolling patients in randomized controlled trials. And there is one called Solidarity, which is the large WHO trial of various treatments, including remdesivir, which is still going through regulatory approval in South Africa. But hopefully, we would be able to put these patients in randomized trials, so they may get one of these treatments, but we'd also collect appropriate data. But right now, no hydroxychloroquine, thank you, no chloroquine, no Alluvia, no steroids, no nothing. Until there's better evidence. But please do try and put people in trials if you get the opportunity. Management of hypoxic respiratory failure. I'm not going to go into this in detail. This is largely ICU territory. It's not my territory at all. It is written in quite detail in the document, which you'll be able to see. But when interestingly, there in someone who's failing standard oxygen therapy, so then you're looking at somebody who's on a rebreather mask, whose sats are dropping, then high flow nasal oxygen, if you have it, may be appropriate. It's just a case series of 15 patients from Stellenbosch, from Tygerberg, where they changed their strategy from intubation to high flow nasal oxygen, and they went from 100% mortality to a 10% mortality. Now that's just observational, but there's a suggestion that high flow nasal oxygen might be a good strategy, and certainly in a certain phenotype, and CPAP also might be possible. Prone positioning, lying on your front, seems to be beneficial. And it seems to be a very little risk. So lying somebody on their front when they're not intubated is probably helpful. And then patients may require intubation and ventilation. And like as I said, I'm not going to go into that because it's not something I'm an expert on at all. But there are various techniques for protecting the lungs, etc., in patients who are ventilated. So that's treatments. I mean, treatments, as I said, mostly it's basically oxygen and maybe ventilation. That's basically what you have. This is de-isolation. So this is something which causes a lot of confusion and for which there isn't huge data. And different places and different parts of the world are doing slightly different things. And the question is, when can you safely send someone back to work, send someone back to an old age home, which is obviously a very vulnerable area. And at the bottom there, it's the idea of repeating a PCR is completely out. That was in the guidelines at one point. A PCR on someone who's 2 weeks into treatment is of very little value. If it's positive, it might mean nothing. If it's negative, it might help, but a positive test doesn't help because it could just be a false positive, a bit like you get in treated gene expert TB patients. So the guideline is in an asymptomatic patient who has a test. Hopefully we won't be testing too many asymptomatic people, but de-isolate after 14 days after a positive test. People with mild disease, so people go home, 14 days after onset of symptoms, and severe disease 14 days after clinical stability. And clinical stability really means no longer needing oxygen. So this is a guide. It's, like I say, it's not based on rock solid evidence, but it's better to have a guide that everyone can follow that makes sense. And so that's our current guideline. So what's new in the guideline is advice for children, newborns, pregnancy, and HIV. These aren't my areas, but I've read them through, and there's actually not a huge amount to say. I've highlighted a few of the areas, for each one, but there isn't a huge amount to say. For children in general, they seem to have a similar but milder form of illness to adults. So the case definition is essentially the same, although they've used sudden onset of fever or history of fever as a prerequisite, but then cough, sore throat, shortness of breath as their case definition. Otherwise, children get treated similarly. Most will have a very mild disease. They need to have the same infection control as possible. If they deteriorate, then they need oxygen and possibly intubation. So they have the same tests. So really not a massive difference for children in terms of the clinical picture or the clinical treatment. Other than that, unlike pretty much every respiratory pathogen we've ever known, for some reason, children seem to do better than adults, which is a huge blessing in this illness, but also a little bit unexplained. And in terms of newborns, so interestingly, a newborn, this is a baby born to a positive mother, is what they're discussing. The guidelines proposed was that as far as possible, the newborn should not be separated from the mother. That's interesting to me because I was advised by a pediatrician that they were suggesting the opposite, that a positive mother's child should be taken to the nursery away from the mother. But the guidelines that have been written here suggest should not be done, and the newborn should stay with the mother. But the mother should practice the best in, IPC that she can, hand hygiene, face mask, etc., to try and prevent the baby becoming infected. Although I'm sure that's going to be very, very difficult. Asymptomatic babies, it seems to be that the newborns who do get infected do really well as well, like other children. But if they should become unwell, then it's similar to adults and children. They need to be isolated, so a closed incubator or an isolation room, and they suggest a test on day 3 of life if they meet the case definition. Or another time. So in the first 3 days, they may get false negative results. But on day 3 and possibly on a repeat on day 5 would be the ideal test for a newborn. And clearly an unwell newborn could have multiple other things other than COVID. Pregnancy and breastfeeding. So again, very little that's different. There's no data indicating that pregnant women are either more at risk of getting COVID, or they get worse outcomes, or there are worse fetal outcomes. So pregnant women essentially are treated in exactly the same way based on the data that we have right now. They should have, what they shouldn't have is any less attention because they might have COVID. They need to have the same antenatal care. And that goes for that goes for everything. I mean, children need to not miss their immunizations because of fear of COVID, etc. For people living with HIV, there's a specific section, and again, there isn't a huge amount to say because, a bit like pregnant women, well, at least there's some data for pregnant women and breastfeeding women that there doesn't seem to be an issue. For HIV, there's limited data, so we can't say really one way or another whether there's a big issue or not. Clearly, it makes sense. We know that other respiratory infections do worse in HIV, pneumonia, influenza, and TB. And so we don't want people with HIV, we don't want anyone getting COVID. We certainly don't want people with HIV getting COVID, but we want to do the best we can for them. So getting people on therapy, getting them suppressed, getting them an influenza vaccine, all things that are already indicated, we need to do better than ever. Otherwise, just the same precautions as everyone else. And I said we would talk a little bit about differentiating PCP or PJP from COVID. We're anticipating that being very difficult. It's going to be patients who are in hospital generally. We're expecting to see bilateral infiltrates and hypoxia, and a normalish, lowish white cell count. So things that would push us against it, of course, would be a very high CD4 count would be against it. The duration of symptoms may be helpful. As I said, it's rare to present with COVID having been sick for more than 14 days. Usually you will have presented before then. And the median duration of symptoms for PJP is 3 weeks. So if someone had a symptom duration of 4 weeks, then you would think COVID unlikely. If it's 2 weeks and if it's 1 week, you would think PJP unlikely. But it's going to be difficult. And so we don't usually use routine beta-D-glucan. I don't advise it because it's usually not necessary, only in some cases. But we think the differential diagnosis has changed quite a lot. Previously, it was really TB, HIV, community-acquired pneumonia. TB, community-acquired pneumonia, PJP. Those are the 3 big differentials in these respiratory cases. Now you've had a 4th thing to the differential. Now it's community-acquired pneumonia, TB, PJP, and COVID, which makes PJP that much more difficult. So we're suggesting an upfront beta-D-glucan. There was a debate about the use of steroids, because we know that in mild to moderate PJP that steroids are beneficial. We don't know that they're harmful in COVID. There are trials, some people think they might be beneficial in COVID, and so they are being used in some trials. I think that's unlikely to be true, but the suggestion was that we do continue to use steroids if we think PJP is likely. That was a judgment call, but that's what the guidelines have come up with. Actually, so that's actually the end of my slideshow. I do have the whole guideline on my laptop, which I can share things with you if you want. But why don't we go to some questions?
Thanks very much, Tom. I'm just looking in the question and answer section, and I don't see any questions coming up there.
I don't see any.
I've got a few myself. Shall I just
Please,
fire a few?
please, we haven't lost any
Okay.
participants. That's usually a good sign. Well, we
Okay,
might have
the
lost a
first
few,
one,
but most of them are still there.
yeah, the one question is, in terms of managing patients at home, there's been this question around silent hypoxia, where patients are pretty much walking into clinics looking pretty well, and when you take their sats, I know it makes it difficult. Would that reduce activities of daily living? This kind of, I don't know how common it is, or if it's a factor.
Nobody knows. I mean, the point really is that nobody knows how to do this. This is a key research question that we really, if I wasn't doing this, what I am doing, I would focus on it, because it's a key question. How do you determine whether someone is developing silent hypoxia or hypoxia, who is a gogo, who speaks, doesn't speak English over the phone, or by telling them when to come back? And the answer is nobody knows the answer. In first world settings, they get an experienced GP to phone the patient and ask them a series of questions, and then use their experience to come up with an answer. And even that has not been validated, but that's what they do. In a low resource setting where you're not going to have an experienced physician, we're talking about when there's huge numbers of patients, we're not going to have the capacity to be phoned by an experienced doctor, and if they do, they probably won't speak the right language to each other. So how do you determine how sick people are? And it's ripe for research, and urgent research, so that we can work this out. We can't give people SATS meters because it's too expensive. So at the moment, we're making a best guess, which is to say, are you struggling to do the things you did yesterday because you're short of breath? We don't know if that's correct, but it's the best we can do at the moment.
Okay, thank you very much. I just see some questions coming up in relation to that. Someone's asked, in relation to silent hypoxia, have you noticed any South African patients with COVID toes? If so, do you put them on oxygen immediately?
Okay, well, I'll let you into a secret. I have yet to see a patient with COVID. So this is all, there are people, I have not yet seen one. We haven't got one in our hospital. The patients and outpatients, they all go home. So maybe whether they had COVID or not, they all went home. So we didn't look after them. So I haven't actually looked after an inpatient with COVID. So everything I tell you is just from what I've read. I haven't seen anyone with COVID toes, but I've seen all the pictures. I think most people have. Do you put them on oxygen? I would imagine you only put them on oxygen if they're hypoxic. I would imagine. I don't know the etiology of the toes. Maybe somebody does. Does anyone know the etiology of the toes? I'm not clear, but I think they don't have oxygen if they're hypoxic.
Yeah, I mean, that would probably be more a case for anticoagulants, I think, from what I've read.
Anticoagulants, well, let's just discuss anticoagulants. Yeah, sorry. Let's just mention anticoagulants while we're there, because it's a fascinating area. It does seem to be a highly hypercoagulable condition, COVID, and as you said, we're seeing people presenting as a young stroke, with chest pain, with troponin leak, with normal coronary arteries, and DVT and other things. The question is whether people should be routinely anticoagulated. Nobody's really sure. It's a research question. Again, I think there are multiple studies going on looking at this. I would suggest that at the moment we make sure that we give people standard DVT prophylaxis at the very least, so we don't get that wrong, and that everyone in hospital is on DVT prophylaxis. Whether they should be having an aspirin or more anticoagulation, I think, is something we need to wait for some rapid research on.
Okay.
I will be enrolling to do my PhD in this research topic in South Africa. Fantastic, Nadia. I'm delighted to hear it.
Here you go. Can you lubricate the test swab with sterile normal saline to reduce friction, pain, especially for nasopharyngeal swab tests?
I'm sure you can. I don't see any reason why a sterile saline would make any difference to the test. So it's not going to inhibit the PCR, and it's not going to prevent what you pick up. So I think I've seen no reason to think why you couldn't do that.
Okay. someone's just mentioning about anticoagulants, but I think it's an area of research. I have another question. The use of vitamin D seems to augment the innate immune system, and maybe in the same way as BCG. I don't know because I noticed that was part of the treatment guidelines at the Joburg Gen initially. I don't know if there's anything here around vitamin D.
Yeah, so the Joburg Gen ICU put out some treatment guidelines which were roundly criticized by everyone else.
Okay.
And I've seen I've seen one from America claiming to be, the elixir of life, including vitamin D, vitamin C, vitamin this, vitamin that.
Yeah.
There's no data. I mean, you probably don't do any harm by giving some vitamin D, but really you need to enroll someone in a trial if you think this is going to work. I mean, vitamin D has been thought about for every infection under the sun, including, no pun intended, including TB. And so far we have very limited data that it is of any use, but it probably isn't of any huge harm. But really this is an area for study, as with vitamin C, all of these things. But, as the guidelines say, there is no evidence to routinely recommend any of these things right now.
Okay. Okay, here's another one. How long after resolution of symptoms does viral shedding in stool continue? And this was probably relevant for the SARS. I remember stories about stool.
Yeah,
SARS epidemic.
I don't have a number on top of my head. I'm sure you could search that quite easily. I don't know the answer to that. If it is viral shedding, you always, if you're going to look that up in a paper, you want to know it's more than just a positive PCR. You want to know that it's a viable virus if you think that's relevant to transmission. I don't know the answer. It may go on for some weeks. We know that some people have had positive PCRs up to 37 days, but we don't know if that's really viable virus. Sorry, I can't give you an answer, but it would be quite easy to look up, I would think.
Okay. Are there more?
Any evidence of sexual transmission?
Yeah.
So there's various. I mean, again, it's a bit like the symptoms thing. People say, well, there may be virus in semen. I'm like, well, that's only really. I mean, to my way of thinking, that's only really relevant if it's present in semen but not in saliva, because generally when people are having sex, they're quite likely to swap saliva, and so whether it's in semen or not seems fairly irrelevant to me, unless it's not in the saliva at the time. And I haven't seen anybody present that. I've just seen people say it's in saliva. And it's like, well, if you do have sex without kissing someone, then maybe that's relevant, but that's probably not hugely important.
Okay.
I don't think. I mean, maybe someone can clarify why they think it's important. Given that we know it's spread by respiratory secretions, because
it's also a close contact encounter. So
it's hard to have sex without being a close contact in other ways.
Yeah.
So I'm not sure how important it is to know about sexual transmission. Really.
Another question. There's not another one. No, there are. Any ideas about possible protective effect of being on ARVs?
Yeah, so there's one very good, quite small but reasonably well conducted study of lopinavir ritonavir as a treatment, not as a protective agent, and it had no effect as a treatment. So we think lopinavir has of no value as a treatment. There's no data on it being protective. I think people are probably less excited about it because it doesn't seem to work as a treatment. It would be interesting to collect. We have a very good natural experiment in South Africa, in that we've got people on lopinavir, and we've got reasonably well matched people on other ARVs like efavirenz. And so a case controlled study to see if lopinavir was protective in South Africa would be interesting. Would be an interesting study. I think the excitement has slightly waned since we found it wasn't a good treatment, though. But there is no data at the moment to say it's protective now.
Okay, thank you. Then what is the view of in South Africa for treatment with plasma?
Same with all the treatments. Currently no evidence. And the question is, so you should only be doing it as part of, so plasma being, I think what Magdalena's talking about is convalescent serum. So that's essentially where you take the antibodies from someone that's usually what people mean when they talk about plasma, is convalescent serum of patients with antibodies in. Personally, having looked at the literature, this has been tried in pretty much every infection under the sun, and it's never worked. So personally, this is just a personal view, I'm very unenthusiastic about this. It was tried for Ebola. It was the most ridiculous thing ever, because the idea, what you have to do is find someone who's recovered from this illness, put them on a plasma machine, take out all their plasma, concentrate it, and then test it for all other things, and then give it to someone else. Getting that plasma in an Ebola situation, when you couldn't dialyze anybody, you couldn't get any machines to work. There's a lot of stigma, was kind of pointless. And then they gave it in a randomized trial, and with no surprise to me, it was completely ineffective. So look, it might work, but my personal view is I'm very unenthusiastic about it. It's hugely labor intensive, hugely costly, and probably of no use. I'm happy to be proved wrong.
And it would probably require patients that have been quite ill with COVID to develop those antibody response to actually be able to get much.
Maybe I'm not sure. I don't know how sick you have to be to get the antibodies levels relate to how sick you are or not. Maybe it might well be that. Yeah.
Okay, I see that's. I just have one more question relating to your first slide. In terms of using rapid antibody tests, you said that it's no good for diagnosis, and we know that. But is there a role, and are there any effective rapid tests for kind of surveillance within the community when we're not having a very good testing strategy at the moment? So at least we can find hotspots.
Yeah. So you'll only find them after the event, because antibodies take a couple of weeks to come up. So if you do find a good antibody test, and there was a report on the BBC today that there is a good test at last, because the ones up to now have been not very good, then you're still only going to pick people up after they're infectious. So if you did lots of serum testing around the community, you might find a hotspot that you didn't find in another way. And if you hadn't found it because you'd seen lots of cases coming into your clinic, or lots of sick people coming to hospital, then you might find a sort of a silent hotspot. But I'm skeptical that's going to be hugely beneficial. I think obviously it's useful for seroprevalence in terms of planning, and it would also be useful if, and this is a big if, those antibodies were shown to be protective against infection, because yes. then you've got a rapid test where you can say, oh, you're protected, you can go back to work. Potentially, that's called an immunity passport. Even if that immunity passport only lasted for 6 to 12 months, because we don't know, but that's a big if. We don't know how protective those antibodies are. So I can see some roles for it, but I'm not sure picking up hotspots is going to be because it's too late, and you'll probably have got a signal. Depending on your testing, you'll probably have got a signal before that there's a hotspot, but I could be wrong.
That makes sense. I think we've got 2 minutes left, and I see there's one last question at the end here. Any ideas about possible reinfection and how long it takes? It might take before it occurs. Yeah,
so it's the same point as we discussed about whether antibodies are protective. Nobody's quite sure. I haven't seen any very clear reports of someone being reinfected, and you would think, with multiple millions of people having had it, you would think if reinfection occurred in the first 2 months, then we would have heard about it by now. So I think you would expect people to have been reinfected. So I think reinfection in the short term is probably not likely. How long that, I think we would have heard about it by now. Robustly, we've heard some not very robust things, like people still having positive tests a month later, but that could be just hangover from the previous, just DNA hanging over from the previous infection. So we haven't really seen that. The best guess, and I know someone who works on this in Oxford, who's a vaccine guru. Her best guess was that about 80% of people, 80, would be protected for about 2 years. That's a real round number of what she thinks might be the case, but don't hold us to that. Lelwa, I'm not sure I heard you. Understanding repeating the test after 2 weeks is not necessary. Correct, it's not necessary. We don't know how to interpret it if it's positive. If it's negative, we're happy that you're not infectious, but if it's positive, we don't know. because it could be, I think most people know that GeneXpert remains positive in people who are cured from TB. In the same way, PCR for COVID can remain positive in someone who's no longer infectious. So we're not, and also, of course, our whole testing strategy is completely overrun at the moment. So we're unable to do those tests, but also we don't think they're of value. So there's no repeat testing.
I think that's all we've got time for. Thank you so much for that talk. It was very informative. I see it's been recorded. I'm sure Prof. Musa will put it on his website. Thanks very much, Tom. That was great.
Pleasure. Okay, thanks.
And just to let everyone know, there's another half an hour talk now. I'm going to hand over to Vanessa, and they are working in the mental health field and mental wellness, I think. I will hand over to her. Just hang on. How do I get there?
Thank you, Michelle, and thank you, Dr. Bal. That was a fascinating talk, and especially since the cases haven't really started arriving in the hospital setting yet. So very, very informative, especially the POI. I thought that's fascinating. So, you know, do we start practicing these new, well, not new case definitions, but what we think could be more predictive, or should we be waiting for the new NICD guidelines and the new case definitions? So thanks to everyone who's still on. I'm Dr. Vanessa Govender, and I host this session together in collaboration with ICAS. And ICAS has been offering debrief sessions to healthcare workers. And we are now at the point where the mental health, and I think just generally the stress amongst healthcare workers is not being undermined, that we do recognize it as a psychological first aid, you know, as we do medical first aid. So I don't work directly in the mental health space, but certainly I'm facilitating this session together with ICAS and a colleague who comes on to do a bit of breath work. So I don't see, it's Pearl that we are waiting for, and I don't see that she's joined us yet. So if you give me just a few seconds, I'll try and contact her. Apologies for that. Okay, Pearl has just joined us. Pearl, can you probably unmute and switch on your video? I'm just going to unmute on my side. I see her in the chat box, but I'm not sure what's going on. Hi. Oh dear. Michelle, are you still there? I think somebody's trying to come on. All right. I think Pearl is is online. So if I may just introduce Pearl, she's a registered social worker, and she's got experience in the employee wellness sector for over 4 years and currently employed as a trauma specialist specializing in groups, families, and individual counseling. So, hi, Pearl.
Hi, Vanessa. Can you hear me now?
Hi, and yes, hi, and welcome. Thank you, Pearl. I've just done an introduction. So I'm going to hand over to you, Pearl, and I'll monitor the participants and the question and answer in chat box. So over to you. Thank you.
Thank you so much. So I would just like to start off by asking, is there anything in particular that people would like to maybe discuss today, especially regarding obviously the functioning during this time as professionals? Is there anything that anybody specifically would like to talk about? Okay, if not, I'm just going to, can you guys all see the screen that I'm sharing?
Yes, that's great, Pearl.
All right, great. Okay, so I'm going to just talk a bit today about mental wellness, because it is obviously, as you mentioned, Vanessa, it is a trying time for everybody, and particularly the people who have to be strong and show up on a day-to-day basis for everybody else. So I would like to encourage, obviously, everybody to engage at any point in time with me if there is something that comes up and that they see or that they would like to comment on. That will be quite helpful. Okay. Can you, everybody hear me?
Yes, you're coming through well.
All right, 100%. Then can everybody see the slideshow? Sorry, what are you seeing on your screen, Vanessa?
Where do you, oh no, okay. You're back to self-care. I think that's your first slide.
The main, okay, 100%. So I'm just having, sorry.
Pearl, we can't hear you.
Vanessa?
Right, you're back on now.
Am I back on? Okay, so I think I'm just gonna stop sharing because that might be causing the issue. Is that okay?
There is a bit of a lag when you do share, so probably just be a bit patient with it if you want to try again. Otherwise, please feel free to go ahead.
All right, so as I said, I'm going to be talking a bit more about self-care today because it is something that we all have to exercise each and every day as professionals, especially because of the fact that we do not know on a day-to-day what we're going to be dealing with. And it is so much more important for us to be healthy at this time and to ensure that we exercise self-care each and every single day.
Paul, we've lost you again. Apologies for this. Thanks to all the participants who are still hanging on. Please hang in there.
Can you hear me again?
You're back now.
All right, I'm just going to switch off my camera to make sure that there isn't any technical issues anymore. Is that okay?
That's fine. You may share your screen, and or you want to stop sharing your screen as well. That's fine. Go ahead. Thanks, Paul.
All right, 100%. Okay, so I'm going to be talking about mental health, and obviously mental health includes our emotional, psychological, and social well-being, and it affects how we think, feel, and act, and it also helps determine how we handle stress related to others and how we make decisions. So the world is affected, obviously, at this moment by the pandemic, which is COVID-19. And just because you guys are healthcare workers that are expected to wear capes and save the world daily does not mean that you guys are not affected by the stress that the outbreak is causing. So everyone reacts differently to stressful situations. And it is important now more than ever for you guys to exercise self-awareness and to ensure that you guys take care of your mental health, because it's a vital component of your mental well-being. So today we're just going to be touching on the component of self-care, and I'm sharing some practical ways to ensure that you guys exercise self-care, because when you are dealing with positive mental health, it will allow you to realize your full potential, to cope with stresses in life that we all engage in every single day, and work productively and make meaningful contributions to the communities which you guys are doing on a day-to-day basis. So what is self-care? Self-care is any activity that we do intentionally in order to take care of our mental, emotional, and physical health. Although it is a simple concept in theory, it is something we very often overlook. Good self-care is key to improved mood and reduced anxiety. And it is also a key to a good relationship with others and with yourself in particular. So where do we start with self-care? And it is so important for us to realize, when you start thinking about that question of where should you as a person start with self-care, to really just stick to the basics. Do not try to overcomplicate it, because over time you will realize that you will find your own rhythm and routine of how to exercise self-care, and you will be able to implement more and identify more particular forms of self-care that will work for each and every one of you, because we are unique individuals. And also the other thing with self-care is that it needs to be something you do actively every single day. Hence the word intentionality will be something that you will be hearing quite a lot throughout the presentation. So you must be intentional about doing it, rather than just thinking that it's organically going to happen. And it is an active choice that you must make, and you must treat it as such. And certain activities that you can think about adding to your calendar and announce your plans to people that are surrounding you, so that they can keep you accountable, which will increase your commitment, and actively look for opportunities for you to practice self-care is quite important. And what I often emphasize to my clients is that keeping a conscious mind is what really truly counts. In other words, if you do not see something as self-care, or you do not do something in order to take care of yourself, it will not work as such. So be aware of what you do and why you do it, how it feels, and what the outcomes are of that which you are doing. And then just some of the practical things that you can do in order to exercise self-care daily is that you can create a no list with things you know, or you know you do not like, or you no longer want to do. So this will mean, an example of it is not checking emails at night, or not attending gatherings, which obviously at this point in time we cannot all do, and not answering your phone during lunch or dinner, just so that you exercise a little bit more of mindfulness with each and every single activity that you do. And you can also do this by promoting and ensuring that you have a nutritious and healthy diet. So examples will be maybe cooking at home instead of having takeouts, and ensuring that you have full meals that will take care of every single nutritional value that you may need daily. And then another one might be getting enough sleep. We all know that it is important to sleep. However, it becomes challenging to sleep the more one is stressed, especially if your brain cannot shut off. So this could mean you leaving your cell phone and other technological devices in a different room to encourage time out and mindfulness in the bedroom just before sleeping. And another one is exercising, which we hear daily. But in contrast to what many people think, exercise is as good for our emotional health as it is for our physical health. It increases serotonin levels, leading to improved mood and energy. And in line with self-care conditions, what's important is that you choose a form of exercise that you like and that you will enjoy, which is very, very important. And then another thing will be to follow up and make sure that medically you are okay, because as healthcare professionals, I'm sure it's easy to always take care of other people and remember the well-being of other people, but forget your own. So make sure that you get your regular check-ins and make sure that you are also, in terms of your health, you are taking care of yourself and you're checking in when you have to with your medical practitioner. And then ensuring that you use relaxation exercises and you practice meditation daily could also be quite helpful. You can do these exercises at any time of the day. This could be while drinking water, where you are really mindful of it and you take the time that every single sip that you take or every gulp that you take, you're mindful of how it's going into your body. And when you're walking to see another patient or you're just having a discussion with your colleague, being mindful of how your body is feeling at those times to ensure that you are really present in the moment, which will also help you to be aware if there are any stresses at that moment that you maybe need to take care of. And then spending enough time with loved ones is also obviously always good, because it allows you to just detach from the day-to-day clinician work that you need to be doing and just allow yourself to be free and yourself and to engage about other types of issues that life is throwing us with, or just to actually engage in a time out with people that you like, whether virtually or physically, will also be quite good, because it will help to encourage you relaxing and you spending time with people that pour back into your tank instead of you constantly giving each and every single moment of the day. And then it's also quite important that you realize that you do a relaxation activity each and every day. This could either be walking for 30 minutes to just unwind, or to just go and sit and listen to the birds chirping outside. This will help you yet again to be more present, to be in touch with yourself, to ask yourself how you're doing, because we're so prone to ask other people how they're doing, but we forget about how we are feeling and what we are going through during this time. So that will also foster and could be a very good self-care activity. So another thing that's important is that look for opportunities to laugh. You know, you guys are working in a field that is quite demanding at this time. So look for opportunities to laugh, because laughing is actually seen as a form of therapy. So the more you laugh, the more you release whatever other pressures are on you, which will help you to become more positive and to feel a little bit more lighter. And then another thing you can do is that you can wake up and start the day by exercising gratitude. This could be making a list of things that you verbally are grateful for, because it's important for you to hear your voice saying the things that you're grateful for, whether it be your family, whether it be you breathing without struggle. It could be really simplified by you focusing on the small little things that you see when you wake up, whether it's the fresh air outside, or the birds outside flying, or your children that slept through the night, or you feeling warm and well rested in the morning. It's very important for you to realize that it is not just the negative that's happening outside, but there's also quite a lot of positivity that you can exercise on a day-to-day. And then just another thing is that it is important to realize that just because self-care is important, you need to also know what is not self-care. So it is not something that we force on ourselves to do and something we do not enjoy, because if you are forcing something on yourself, it means that you're not really enjoying it, which means that it's not part of your self-care activities that will contribute to your well-being. So there's a lady by the name of Agnes Wayman who said self-care is something that refuels us rather than that takes away from us. So self-care isn't a selfish act either. It is not only about considering our needs, it is considering rather that which we know we need to do in order to take care of ourselves, being subsequently able to take care of others as well. So that is, if I don't take good care and enough care of myself, I will not be in the place or the position to give back to my patients or to my loved ones. So it is very important for us to be mindful of what is not self-care so that we can know what is self-care. So that is it from my side. Is there anything that anybody would like to ask?
Thanks very much, Pearl. I think there were really some nuggets of wisdom coming through there. I don't see any questions coming through from the participants, but certainly from my side, I think just, the expression of gratitude. In fact, yesterday I was at a clinic and one of the nurses actually mentioned that to me, that she just can't wait to get home to be with her little 3-year-old and just appreciate those few moments of love and care that you get from just being with your family members. The intentionality, of course, is where we're heading now, with Beju, who's our panelist, who's also on the line, just to take us through some breath work and to make us just very conscious of that effort that we have to make in self-care. So thanks, Pearl, and I don't see any questions coming through, so we'll go straight into some breath work. Thank you, Beju. See, Beju's on the line.
Hi, can you hear me now?
Yes, we can. I had to unmute. Thank you. Welcome.
Thank you, Vanessa, and thank you, Pearl, for your pearls of wisdom that you've just spent a few minutes on. Welcome, everyone else. I think some of you have done some breath work with me a good few weeks ago. So I'm going to actually repeat 2 of the techniques, just because maybe you've forgotten and you haven't been practicing as much as you would have liked to. But also piggybacking on Pearl's whole discussion on self-care and how important it is. I think we've done with 7 weeks now of lockdown, and look, I'm not sure that I'm pretty sure we'll get a little bit more back to normality, but I think, there's still a lot to come. And therefore, it's really important that you spend that time on self-care. One of the ways you can do it is a very easy and inconspicuous way, because sometimes you're on the job and you need some way to de-stress, is actually to tap into your breath. So what I find is most of us live very much in this fight-or-flight mode. So the first breathing technique that I'm going to work through with you is to actually move away from that fight or flight mode and actually tap into what we call our vagus nerve. And that nerve helps to calm the whole nervous system down. So without taking too much more of your time, because I know we're all trying to get out of here in a few minutes, we want to start finding a way to breathe that allows us to find that vagus nerve and to actually calm ourselves down. So I want you to just start by placing one hand above your belly button and one hand below. And then just slowly start to breathe in and out through your nose. What I want you to be conscious of is what's happening when you breathe in. Is your belly filling up, or is it kind of flopping down? So what you want to happen on your inhale is for your belly to actually fill up like a balloon on your inhale. And as you exhale, you want your belly to flop down towards your spine. Many of us breathe in the opposite way, and that's actually not the correct way of, one, also stimulating your lungs to get stronger from using your breath. So let's do a few rounds of that. Just inhale and exhale through the nose. And inhale, making sure your belly is puffing up. And exhale again through your nose, allowing that belly to flop down. I'm going to start adding a count to your breath. So we're going to inhale, 1, 2, 3. Exhale, 1, 2, 3. Inhale, 1, 2, 3. Exhale, 1, 2, 3. Inhale, 1, 2, 3. Exhale, 1, 2, 3. So now we're going to start making our exhales slightly longer than our inhales. And what that does is it actually stimulates that vagus nerve. So the longer your exhale is to your inhale, the calmer you'll feel. So maybe today you'll only be able to inhale for a count of 3 and exhale to a count of 4. As you practice, try and practice so that your inhale is a count of 3 and your exhale becomes a count of 6. Then you can go inhale for a count of 4, exhale to a count of 8. And this one will really calm you down, and 2, it really builds lung capacity. So let's just do a few rounds of inhaling for a count of 3 and exhaling for a count of 4. I'll actually count to 5. If you can manage going up to 5, that will be amazing. So let's start. We'll do 5 rounds. So before we actually start the technique, maybe take a big inhale through your nose. And exhale, sigh the breath out through your mouth. And let's start. So inhale, 1, 2, 3. Exhale, 1, 2, 3, 4, 5. Inhale, 1, 2, 3. Exhale, 1, 2, 3, 4, 5. Inhale, 1, 2, 3. Exhale, 1, 2, 3, 4, 5. Inhale, 1, 2, 3. Exhale, 1, 2, 3, 4, 5. Last round. Inhale, 1, 2, 3. Exhale, 1, 2, 3, 4, 5. Slowly allow your breath to find its natural rhythm. And then just mindfully see how you feel, whether your body and your mind feels a little bit calmer. I hope it does. So this is a technique you can use on the job. Nobody needs to know you're doing it. You can do it while you're taking that 30-minute break to give your self-care to yourself, whether you're sitting outside listening to the birds or taking a walk. But also something you can do before you get out of bed in the morning, maybe during your lunch break, and even before you go to bed. It's also a great technique to help you calm down before you go to bed and hopefully get a better night's sleep. I think all of us are experiencing high level of anxiety and tension because we're working in a world of a really big unknown. So use these techniques, use this very simple technique to help you calm down. And even if you just do up to 2 minutes, it is very, very effective. So 2 minutes at a time, maybe a couple of times a day, or when things just get too overwhelming at work, you can apply this technique. You can teach it to your family, your friends, even your patients if they have strong lungs, just to help them calm down. So from my side, I hope that's been beneficial to you and it's something that you can use throughout your day and that it helps to calm you down. Next time I see you, we'll try and work on another technique. And in the meantime, I wish you all the very best. Just big kudos for being out there in the front line and taking care of all of us and all our needs. Make sure that you take care of your own. Have a wonderful afternoon, everyone, till we meet again. Take care. Thank you so much, Vanessa, for giving me the opportunity.
Sure. Thank you, Beju, and thank you to all the attendees who are still on. I think on that very calming and mindful note, I shall bid you all farewell. Have a great week. Stay safe out there, and we salute all the frontliners out there. Thanks to the panelists. Thank you, Beju and Paul. Have a good evening. Bye now.
Bye. Good afternoon.